that care. What is not an eligibility criteria will be an exclusion if there's a disease that is not life-limiting, okay? Management of persistent pain in the absence of a life-limiting illness. Or if somebody has mental health needs, they need counseling but without a life-limiting illness, or they have no symptoms. You have to have symptoms that need to be managed in order to access that care. Can you advance the slide, please? Palliative care consultations are covered by Medicare. There's a one-time consultation that is covered by Medicare that would entitle a person to have a physician or a nurse practitioner assess them, write prescriptions, make referrals for different kinds of treatments and therapies, and continue to see them on a consultative basis and get renewed every 60 days. They're only on palliative care as long as they have those symptoms. Once the symptoms discontinue, they would discharge from the care. Can you advance? But then we talk about hospice. So that's palliative care. It's an extra layer of support. You could get it when you have any kind of a life-limiting illness, and you could continue to have all of the physicians and specialists that you have. It does not change anything. If you have a home attendant, you have anything, you could continue to have it. But then you have another kind of palliative care, and that's called hospice. So I want to distinguish now between hospice and palliative care. Hospice is a subspecialty of palliative care. It's a kind of palliative care. Just like, I like to say, just like all subways are trains, but not all trains are subways, it's the same thing. All hospice is palliative care, but not all palliative care is hospice. So hospice is a special kind of palliative care that a person would access at a certain point in their disease trajectory, in their disease course, and that would be when they are no longer seeking to cure their disease, and when the physician would say to you, the treating physician, if it were an oncologist, for example, Dr. Kaplan, if he were to say to his patient, we've tried everything, we can't cure this disease anymore. We just can't do it. And you should be looking into another care option. You should consider hospice.
What does this mean, the NHPOC?
I'm going to tell you. So there's an organization called the National Hospice and Palliative Care Organization. It's a national body, membership organization of all hospices and palliative care organizations, and they collect data. And they collect an enormous, enormous amount of data. They put out surveys, they put out statistics, they put out reports, and the widest, broadest and most popular response in family satisfaction surveys from people who have experienced hospice for a loved one is, I wish we had known about hospice earlier. Where does that come from? Why would that come up as a response in family satisfaction surveys? I'm going to go into it. Can you advance the slide? People seek hospice when they become aware of it and when they are told to look into it, or when a person says, I don't want to be butchered anymore, or this chemotherapy is killing me, and I just want to be comfortable. I want to live my life. And that would be the types of scenarios where people would look into hospice. However, you could be on hospice for a long time, just like you could live with diseases for a long time, more today than ever before in history. It's true of hospice also. While the eligibility criteria to get onto hospice is 2, there's only 2 eligibility criteria. The first criterion is that if a physician, if the overseeing physician were to say that within 6 months to a year, it would be reasonable for me to believe that this patient would succumb to their disease process, that's one criterion, that he would certify that their illness is in a terminal phase with a approximately 6-month diagnosis. That doesn't mean they're dying in 6 months. It means that it's reasonable and based on clinical indicators and all that they know about that disease process that they could succumb to that disease within 6 months if it followed its natural course. That's one criterion. The only other criterion is that a person is not seeking to cure their disease. Okay? So this chart shows you when would hospice typically be introduced and how does it get introduced. So what it's showing you is that from the time of diagnosis, a person is diagnosed with a serious illness. At that time, they're seeking life-prolonging therapies primarily. They're getting a lot of life-prolonging curative treatments. However, you can introduce palliative care early on in that disease process so that they're getting the pain and symptom management in tandem with all of the other treatments to cure their disease. As the disease progresses, the palliative care increases in how you introduce it to this person until it gets to a point where they're getting all palliative care and they discontinue, and the physicians recommend discontinuing life-prolonging therapies, and it's at that point that a person would access hospice care, and they would live on hospice care until they succumb to that disease. Although I have to tell you that there are situations that we have where people graduate off of hospice. They actually thrive, they stabilize, and sometimes they thrive and graduate off of hospice. Some situations that you can imagine, when we have patients sometimes that are at Sloan or in very renowned cancer centers where they're well known for experimental treatments and very aggressive types of treatments, and those are toxins. It's poison that you're putting in the body. And sometimes when it gets to the point where there's no more treatments that they can try because they're so toxic, the person looks like they're on death's door. And at that point, the doctor will say, we can't do anything for you. And they discharge the patient off into a hospice. And I have to tell you that there are times that once that patient is off of all of those treatments and their white blood cell counts start to get normalized and their appetite starts to come back and they're treated with comfort care and whatever else they need. They're hydrated, they're getting food, and they're getting all of the comfort and quality of life things that we can do for them. They start to do better. And they can sometimes live for months. And we've had people who actually felt strong enough to go off hospice and continue to get curative treatments. There's no penalty for people jumping on and off. When people go onto hospice, sometimes they go onto it because they're just so debilitated. It doesn't always mean, it's not a vadai, that they're going to be on hospice and they're going to die imminently. The person could actually be on it for months and months.
Excuse me, there's a remedy for arthritis.
Pardon?
A remedy for arthritis.
That has nothing to do with this.
Can you advance the slide? Yeah.
Okay, Medicare will pay for 6 months.
Medicare pays for as long as a person is eligible for hospice. Hospice is covered by Medicare. All of the clinical care that's received on hospice is covered by Medicare. If a person has Medicaid, it is also covered by Medicaid. Okay, when is hospice indicated? I just told you that, so we're going to pass over this slide. What are the different types of diseases that you would typically find people on hospice struggling with? All end-stage disease, as would be expected, end-stage cancer or some other type of malignancy, end-stage pulmonary disease, cerebrovascular disease, Alzheimer's, liver disease, ALS, cardiac disease, renal failure, and AIDS. Now, I have to tell you that today, and what we heard from Dr. Kaplan is true. The people are living longer and dying less from cancer. The cost of people with end-stage Alzheimer's has now surpassed many of the other disease processes, and the cost of care and custodial care and the other comorbidities that go along with end-stage Alzheimer's. Can you advance the slide?
What chemovascular disease that was?
Pardon me?